Nishantan, shall we start then? It's about we have
Yeah, I think, man.
wait. I think
They are
7:05
yeah.
now.
Yes, sir.
Uh,
Yeah, we can start, no?
we'll start. No? Okay.
Yeah.
Okay.
Yeah.
Okay. So for the Uromet session 2.13, and thank you very much for joining with us today for Uromet session on Euro technology. And we are going to have 5 speakers today talking on various aspects of Euro technology. And we are happy to have our resource persons, Professor Neville D. Pereira and Dr. Manjula Herath.
Hello. Yeah.
Dr. Heri.
Yeah, I'm here. Available.
Yeah.
I'm available. Okay.
Okay. So over to you, Prasanna, to present your talk.
Yeah. Prasanna is today presenting laser and shockwave lithotripsy. Your time is 15 minutes. Please stick on the time.
Yes, sir.
We can't actually see your slides.
Yeah.
You can do it screen sharing. Yeah. You can select your presentation and then go to the presentation mode.
Can you see? No, sir.
No, we can't see your slide.
We can't. I think what you should do, go to your presentation, go to share the.
Now can you see,
yeah.
sir?
Yes, we can see.
We can see now. Good.
Okay. Good evening, everyone. I am Dr. Prasanna. Thank you for your time being here. Today, my presentation is the laser and the shockwave lithotripsy. Hello, sir.
Yeah, we can hear
Hello?
you.
Yeah,
Go
I'm
ahead.
hearing. Yes.
So today I'm going to present laser and the shockwave lithotripsy. So first I'm talking about laser. It's a light amplification by stimulated emission of radiation, and the history is behind the laser is initially in 1917, Albert Einstein introduced the theory of stimulated emission. Then in 54, it's developed the MESA. MESA means microwave amplification by the stimulated emission of radiation. Light here microwave. Then in 1960, it's developed by the Theo Mayman. Developed the first laser. It is the ruby laser. Ruby means the red light laser. Then this laser energy consists of some characteristic features. That's mean coherence, collimation, and monochromatic. Coherence mean the waves are in the same pattern. Same pattern mean it's along the same time. And collimation mean they are parallel waves rather than radiate. They are parallel waves, and without losing the energy, they goes in the far away. And monochromatic means the same color. That means the wavelengths are same. Then this is the basic mechanism. So there's a gain medium is there. This gain medium can be gas, liquid, or solid, or semiconductor material. That means like a diode. And there's a external energy source. That's from the any. It can be electrical or light or whatever it is from the external energy source. And it, with the external energy source, initially this orbital electrons are getting the energy, they goes to the higher orbital, and again they back to the low orbital, and it emits some energy. It forms this laser energy. So depend on those laser energy, there are DOP mean that depth of penetration and chromophores. This chromophores means this laser energy are absorbed by some material. So mainly in our body, it's absorbed by the water and the blood. So there are different laser depend on this gain medium. There are CO2 laser, thulium laser, holmium, KTP, that means the red light laser, green light laser, that means potassium titanium laser, and the diode laser. Those are, and depend on those, there are depth of penetration and the what is the chromophores they use. And there are different classes of laser. Actually, there are class 1 to class 4. Again, it can be a normal numbers or Roman numbers. And the medically using lasers are class 4 lasers. What we have to understand from this is class 4 laser, the chance of adverse effects is high. This class 1 laser is normally for the our normal using lights like in the toys and things with the laser. These are class 1 laser, but class 4 laser, the direct injury to the eye and the skin is high. And when we look at the application in laser in the urology, it can be treatment for the BPH or benign bladder obstruction, and ablation of the tumors like bladder cancer or renal cancer. And urolithiasis, again, it can be in the renal, ureter, or bladder. And stricture disease, it can be for the ureteric or urethral stricture disease. We can use the laser ureterotomy or ureterotomy. And laparoscopically, we can use assisted partial nephrectomy or the radical this prostatectomy, sparing prostatectomy. And in the females, it can be used the stress incontinence and genitourinary syndrome of menopause for these vaginal and vaginal dryness, those things. And for the skin condition like genital warts, those things, we can use in the urology. And there are common lasers are carbon dioxide laser, diode laser. Diode is this semiconducting material, erbium laser, and KTP or green light laser, holmium, thulium, and ND-JAK laser, that is neodymium laser. And when we look at the BPH, benign prostatic hypertrophy, this comparison of post-operative outcome of QRP or laser vaporization or laser enucleation. This compared to the QRP, these laser treatments are less complication rate, and the hospital stay are less compared to the TURP. But it has to be matched with the other like prostate size and the other parameters. But overall comparison, the complications and the hospital stay are less with the laser. And when we compare to the urolithiasis, so when these lasers are acting, there's a effect called Moses effect. So it initially creates the water vapor bleb, and it expand and shrink, and which causes the heat transmission and causes the stone fragmentation. So in the stone management, the stone treatment, it can be dusting or fragmentation. Dusting means it can cause the minute particle and eliminate these stones, or fragmentation means a little bit bigger particle. Then when we do the fragmentation, we have to do the basket extraction or any form of extraction. And when we compare for the urolithiasis treatment, holmium and thulium, the newer generation fiber optic thuliums are and superpulsed fiber optic thulium lasers are more effective. So it consists of compared to the water absorption coefficients, these thulium lasers are 4 times coefficients are higher, and these depth of penetrations are very short in thulium lasers. It's around 0.2 micrometer. So the adjacent thermal damage are very minimal in thulium laser, and it can be cause higher frequencies. So when we use the higher frequencies, the dusting mechanism will be high, and these fibers are very the thin fibers. Thulium laser fibers are even 150 micrometer thulium fibers are there, so we can negotiate through the even flexible RIRL, we can negotiate. And these smaller stone fragments, that means dusting, and it causes, when we use the higher frequencies, the retropulsion rates are very minimal. Then adverse effects, so mainly eye injuries, it can be from the corneal aberration to blindness, and adjacent thermal injuries, mainly the mucosal damage to the full thickness injuries, and visceral perforation and skin damage. And when we look at the shockwave lithotripsy, so it's a technical procedure that attempts to break a stone by using the externally applied and focused high intensity acoustic pulse. So it's a like a pulse, acoustic pulse. It use mechanical energy. So introduced in 1980. So it usually used for the renal, pelvic, and calcial stones and the upper and mid ureteric stones. But now, says even for the lower ureteric stones, we can use the ESWL. So when we compare to the other modalities of treatment, mainly ESWL, PCNL, and the URS, the usage of this ESWL now it's dropping, and URS treatments are go more and more. The reasons can be a laser, introduction of laser, and the newer development of lasers, and the this stone fragmentation, stone free rate with the ESWL. So when we compare the ESWL machine, it consists of 4 parts. So one is the shockwave generator and focusing system and coupling mechanism and the guidance system. So there are different, depending on the shockwave generator, there are 3 modalities. And now our newer generation is the electromagnetic one. And the focusing system, again, it can be electrohydraulic or piezoelectric or electromagnetic one. And coupling, the coupling means this mainly this surface, when we there's a surface interface, we have to use the another coupling mechanism. So in the mainly in the 3rd generation ESWL machine, we use the silicon pad for the as a coupling device. And the guidance system means how do we focus the stone. So usually we use the either ultrasonography or the fluoroscopy, that means the X-rays. So we can use the both, or we can use single modality. And evolution, there's from 1st generation to now 4th generations ones are available. This 4th generation one usually use this electromagnetic shockwave machines. And this stone fragmentation, when we look at the mechanism of stone fragmentation, usually it can cause the compressive force and tensile force, and finally it forces the cavitation. So it generates, when the shockwave energy generate there's a water vapor, like the Moses effect. When we generate the water vapor bubbles, they collapse, and it forms the stone fragmentation. Then this success of ESWL, that means the following the ESWL, the stone free rate, it depends on the stone factor, patient factor, and the instrument factors. So stone factors, again, size of the stones, again, that is depend on the location. If it is renal 2 centimeter and the ureter is 1 centimeter, and the that means the location, again, location within the kidney, whether it is the pelvis or upper calyx, mid or lower calyx. And when we look at the lower calyx, again, it is depend on the this infundibular measurements, infundibular width, infundibular length, and the angle, infundibular pelvic angle. Then when we look at the patient factors, again, the patient body habitus, whether skin to stone distance, if it is more than 10 centimeter, again, stone free rate is very low. And this efficacy of the instrument, again, with the newer generation machines, the stone free rates are high. And contraindication, when you look at the contraindication for shockwave lithotripsy, absolute contraindication, mainly the urosepsis, uncorrected coagulopathy, pregnancy, and distal obstruction, and aneurysm near to the stones, mainly the renal artery and aortic aneurysms. And relative contraindications are body habitus, mainly the morbid obesity, and scoliosis, mainly the spinal deformities, and renal malformation, poorly controlled hypertension, and renal insufficiency. Those are the contraindications. Related contraindication. So when we look at portions, so patient with cardiac arrhythmias, so EAU recommend we can use even the newer generation machines we can use. So that is not the contraindication. But American Urology Association, they didn't mention anything about the patient with cardiac arrhythmias. And when we use a patient with anticoagulant like warfarin and clopid, we have to stop. But aspirin, we have to stop 7 days prior to the treatment. And in case of infected stone or bacteria, pre-op antibiotic, we can start the pre-op antibiotic and then we can go ahead with the ESW. And when we look at the pre-op or intra-op stenting, so now both EAU and American Urological Association both they don't reckon for the pre-op or intra-op stenting that means pre-procedure or intra-procedure stenting. But when we see the obstructed pyelonephritis or newly onset renal insufficiency, then there's an indication for pre-op stenting. But this stenting does not improve the stone-free rate in the ESWL or stain starch. It won't reduce the stain starch or infective complications. So that's why they didn't suggest for any form of stenting pre or intra procedure. And when we look at the intraoperative, not the intraoperative, so intra procedure details. So optical shock waves, the 80 to 90 shocks per minutes. And ramping, when we look at the ramping, it will improve the stone fragmentation and protect the kidney by promoting vasoconstriction. So, and tracking the stone burden during the procedure is important because of natural movement of kidney during its respiration. So during procedure we can, but usually we don't do it. But again, that is it will improve the stone free rate. And with the coupling device, we have to remove the air bubbles in between this cushion and the intersurface area. It will again increase the stone free rate. And using proper analgesics, so we have to use the intramuscular analgesics or that proper analgesics to reduce the patient's movement during the procedure. And post-operative management, following procedure, common adverse effects are flank area petechial races and hematuria and passage of stone fragment causing the uretricolic. So we have to do it. We have to properly educate the patient regarding the complications of or side effect following the ESWL, and we can give the adequate oral analgesics and we can combine with the medical expulsive therapy. And main complications are infection and hematoma formation. And renal complications, mainly stain starch, it's usually less than 10%, and it will increase with the size of the stone. The management for the stain starch, usually it's a conservative approach, around 50% settle with the conservative management. But if patient develop the uretricolics, and we can go ahead with the imaging and we can decide on the further management. If the leading stones are obstructing, then we can do the endourological approach. And rarely patient can develop the renal atrophy. And other minor complication, adjacent organ damage, mainly a pulmonary contusion, pancreatitis, splenic hematoma, inadvertent fragmentation of bile stones, elevated liver enzyme, and increased incidence of diabetic and hypertension. Thank you, sir.
Good presentation. You have managed the time well. And now Neville sir, Professor Neville sir also joined with us. I think towards with the experts, Manjula sir and Neville sir.
Hello? Prasanna?
Yes, sir.
Hello?
Yes, sir.
Can you hear me? So,
yes.
What are the advantages? Because even though now it is dying.
Hello, sir.
So we couldn't hear
over the
you.
URS. Can you hear me?
Yes, now can
Yes.
hear me.
Yeah.
Yes, sir.
So, even though it is a dying procedure,
Sir, sorry, sir, I couldn't hear properly.
I think sir wanted to ask whether what is the difference between the effectiveness of URS and
still
also,
use. Hello?
Yeah, you are not clear, sir. Yeah, can you repeat the question, sir?
Hello?
I couldn't hear properly. Sorry, sir.
Sorry, I'm on the way. That's the problem. I'm traveling. Okay. 1 second. Can you hear me now?
Yes, sir.
Hello?
Yes, we can hear you.
Yeah. So
Yes, sir.
Yes.
even though ESW is dying procedure, so what are the advantages of ESW over I mean URS and laser?
Yeah, it is, sir, actually minimally or even non-invasive procedure, and we can for the if we select the patients with a more selection criteria, we can the stone clearance rate are more or less equal to the compared to the other procedures, but the patient selection is important. So these are the main two the advantages, because the over the URS and the PCNL.
Yeah, mainly we can do without anesthesia except kids. And
Yes.
so depend on the medical comorbidities and things, sometimes anesthesia may be the issue. Those patients, what are the stone criteria? You said some criteria, some more is remaining.
Yeah, mainly,
Just to
sir,
consider.
the size of the stone. If it is renal stone, 2 centimeter, or ureteric stone, 1 centimeter, and the
Yeah,
density usually less than 1,000 or even less than 900 is the usually suggested one.
yeah.
And
But if it is low density, what is the lowest limit they consider? So it's a 400 to 1,000, no?
yeah,
900 or something.
yeah, if it is
Yeah, when the
very
soft,
low
it's
density,
a soft tissue calcification things, they don't work with the
it don't
ESW.
work. Yes, yes, sir.
And Neville sir, do you have any questions? The next question is considering the ureteric stones. So depend on the site, upper, mid, and lower, upper and lower. So what modality, either URS plus laser or ESW you prefer? Depend on the site.
If it is upper ureteric, we can prefer the ESWL, but if it is lower ureteric one,
Or
sir,
suitable stone. Yeah.
suitable stone, ESWL is the preferable, but if it is lower ureteric one, then URS is.
And so what are the measures you can prevent stone fragment migration during laser lithotripsy?
During?
Laser lithotripsy, URS and laser lithotripsy, what are the measures you can take to prevent stone fragment migration?
Yes, sir. For the mainly for the retropulsion, sir, we can reduce the energy. Mainly, we can increase the frequencies and we can reduce the energy. So it will reduce the retropulsion, and we can reduce the uh, uh, irrigation fluid rate. The rate of irrigation fluid, mainly those are two things, sir.
Yeah, other thing is that there are various devices, stone, cone, and even you can catch with the basket, and you can even negotiate to guide wire up and curl it down. So that prevent migration of the stone. Another thing, when you do laser lithotripsy, I mean the continuous, the same irrigation pressure and flow will cause counterflow that prevent it migrating up. Even they go up, it comes with the return flow, it comes back to your field. And those tricks you can use during laser lithotripsy. Okay, shall we move to the other topic? Oh, is any questions?
Neville, sir.
Neville, sir?
Sorry.
Yeah, I'm sorry. Due to some technical errors, I missed most of the lecture actually. I think what Manjula said was, I think the important thing to prevent retropulsion. So what we commonly do is to catch it with a Domia basket and maintain a low flow during insertion of the ureteroscope as low as possible, because what happens is sometimes the dilated upper system, the stone just get retropulsed even before you see it. So always maintain a low flow when you are introducing the ureteroscope. Other than that, I think most of the things are covered, isn't it? So biggest problem is that the retropulsion and dusting and fragmentation. I think you have to use the correct settings, and also occasionally popcorning. When you see when you get multiple slightly larger stones, you can do popcorning. I don't know whether it was mentioned. You just, without touching the stones, you hold the fiber in the middle of the thing, middle of the collection of stones, and hold it there, then that also will fragment the stones. So those are the little things I think we have to know about rigid uteroscopy. And yeah.
So I have a question.
Yeah.
Is there an effect when elevating the patient head, then the gravity, will it prevent the retropulsion of the stone?
It's actually speaking, that I think will not be sort of enough to prevent retropulsion. But occasionally there are those maneuvers like elevating the head end and then giving the percussion on the loin can be helpful when you are doing RIRLs, because if the stone is lying out of the field, you can just see a glimpse of it, and you are inside the pelvis with the semi-rigid scope. I think you can turn the patient towards the opposite side, and then one of the people can give some little bit of percussion, jerky movements over the loin, and that might, and you have to just watch the movement of the stone and be ready with a domia basket. Occasionally you are fortunate that these stone will come to the vision, and then you can grab it with the domia basket. So that is the only time I think the mechanical movements will help. But retropulsion is a difficult thing to stop by just elevating the head. Other thing is to slow down the irrigation. If you are doing RIRLs, it's inside the pelvis. If you slow down the irrigation, the pelvis will collapse, and sometimes the stone will come to you. So especially these stones have got displaced inside the kidney. If you are using semi-rigid, reducing the irrigation will sometimes help you to grab the stone with a domia inside the renal pelvis. So those are little tricks, I think, when you are doing RIRL with the semi-rigid.
We have to maintain the same pressure throughout the procedure, especially when we grab one stone and come out, and then the renal pressure drops. So whenever we go back, it goes back to the kidney.
Now I think we can move to the next presentation. Next presentation is diathermy and advanced energy devices done by Chaminda Alahakon. You have 15 minutes to go.
Okay, good evening, everybody. Today, my topic is to discuss about the diathermy and advanced energy devices. So, first of all, before moving to the principle of diathermy, so a little bit about the introduction. So, this was introduced by this William Tribov in 1920 with the collaboration with this neurosurgeon Harvey Cushing. And after introduction of this diathermy, this surgeons has moved easy on doing their surgeons without heavy bleeding. So when considering the diathermy, so we should have some knowledge about these properties of electricity. As we all know, this electron flow generate the current flow to the opposite direction. So this electron flows from this voltage difference, that is the force they are used for these electrons to traverse. And if any resistance which will occurs to this electron flow will cause the impedance. So if there's any impedance, that will generate the heat. And some people have some this confusion regarding this electrocautery versus electrosurgery. Some might think this is the terms are same, but electrocautery, here we use the DC direct current, and this current doesn't traverse through the body. And instead, there is this heated wire comes and contact with the tissue and causing the burn. But in the electrosurgery, we use the alternative current, and the patient also included into the circuit, and current passes through the body. When moving to the principles of diathermy, so usually this current is generated by the electrosurgical unit, and that current travels to this body via this active probe. So the heat generation usually based upon the current density. So the maximum density will be at the smallest surface area where the active electrodes stay. And this current then travels to the body, and that will return to the electrosurgical unit where the return electrode to complete the circuit. And this produced temperature will depend on the time of the contact with the tissue. When considering this frequency spectrum we use in the electrosurgery, we usually use much more higher frequencies like 200 kilohertz or megahertz, which is far more larger than this frequency, which will cause a neuromuscular stimulation. So when considering this diathermy, there are two circuit devices. We all know the monopolar and bipolar. In the monopolar, so it has this electrosurgical stimulator generator and the active electrode, and the current passes through the body and returning electrode is there. When considering this return electrode, it should be made of low resistant material, and also it should be it should have a large surface area with the appropriate size, and it should be placed in a well vascularized muscle mass or muscle mass, and it should not cross the joint. So ideally speaking, it should be applied in the same operative quadrant, and as well as it should not win and should avoid the vascular insufficient area, and as well as high resistant areas such as scarred edematous areas. And apart from that, we should avoid current passing through the alternative pathways where we have to make sure that the prosthesis and ECG electrodes are far beyond this circuit, and as well as patient before entering to the surgery, patient should remove all the metal piercing, and as well as patient should not to be touched with metal part of the table. But with the NEVA devices, now this diathermy burns are less common due to this NEVA electrosurgical units have this contact quality monitoring, where they identify this less minimal less contact with the patient, and the machine will shut down automatically. When it comes to the bipolar circuit, so the difference is that in here the current doesn't pass through the patient's body. Instead of this active and return electrodes are located in the tip of the instrument. So current passes from this active into the tissues in between the tines and return via the returning electrodes to the unit. When we consider about this tissue effect with the different waveforms, so as we all know, there are two major waveforms. One is the cut-in and the coagulation. In the cut-in form, we use this low voltage continuous current, where this during this period, this electrosurgical unit will work on 100% time with very low voltage. So depending on whether we are touching the tissue or not, we can produce two different types of cutting. One is the pure cutting, and another one is the desiccation. If we held this active electrode a little bit slightly away from the tissue, then that will cause this vaporization of the tissue and more precise cutting. And if we keep it touch with the tissue, that will cause this drying out the cells and forming coagulant, and rather than vaporization, and that will associate with the cutting as well as some form of coagulation. And in the coagulation settings, so we use the high voltage with the intermittent current. They are only about 6% time the machine would work, and that by using that also we can produce either coagulation or fulguration or sprain mode. In the coagulation, where what we do is we by using this coagulation mode, we can cause this spotting, denaturation, and the shrinking of the tissue forming coagulant. But in the fulguration or sprain mode, we keep the active probe a little bit away, that will causing this electrical arcing and charring of the tissue or a wide area, which we can use, especially when we are using this partial nephrectomies. And apart from that, we can use the blended waveform, where this is a combination of both. So the voltage will be moderate, so it can produce very degree of cutting as well as the coagulation. When it comes to the endourology, both monopole and bipolar devices are used in endourology, especially in this transurethral resection. So in the monopolar setting, this active probe will be this receptoscope, a loop of the receptoscope, and the returning pad is as same as the conventional diathermy. And this bipolar, so this returning electrode would be the most of the time this sheath of the receptoscope, especially in this tourist system. When moves to the hazards of electrosurgery, so the most common one would be this electrothermal injuries. So that those electrothermal injuries can happen in any surgeries, or some electrothermal injuries which are specific to laparoscopic surgeries. So among these common to the old surgeries, the diaphragm pad burns was common in earlier days, but now it is almost not seen due to this contact quality monitoring devices. Another thing would be this insulation failure, which will result in damage to the nearby other organs. When it comes to the laparoscopic surgeries, so this coupling causing the damage to the surrounding tissues. So first thing would be this direct coupling. What happened there? This active electrode might contact with the other metal instrument inside this during the laparoscopy. That will create do this conduction of current and causing the damage to the surrounding tissues. So to avoid this, we have to avoid this activation of diathermy when there is a touching or in close proximity with other metal instrument. So the indirect coupling, this occurs due to the development of capacitors whenever there is a two conductors are separated by a non-conductor. So and when considering the laparoscopy, we usually use this active electrode, and there is this insulation which acts as a non-conductor, and as well as we have usually we use the metal trocar, which will act as a second conductor. So in between there will be this formation of capacitor that will generate the electrical impulses even without this activation of the diathermy, which will result in the damage to the collateral structures. So, but as shown in here, by using this plastic trocars, that won't eliminate this risk, but it will reduce the risk. But this indirect coupling is more with this hybrid cannular system with metal and plastic trocar. Other hazards include there will be this fire and explosion, especially when we use this alcohol-based skin preparation, and as well as this electrosurgical smoke can cause carcinogenic, and as well as some says that some study shows that there may be a spreading of viral infection as well. So the smoke evacuation is preferred. Moving into this other advanced energy devices, so the tissue energizer or the advanced bipolar ultrasonic devices, they use combined electric surgical energy and mechanical energy with combination to vessel sealing. First, we'll move on to these advanced bipolar devices. In our practice, we commonly encounter two these manufacturer devices. One is the Ligashow and another one is the NC. So here we use this bipolar current combined with the optimal mechanical compression by the jaws of the instrument. So by those instruments, usually vessels up to 7 millimeter diameter can control with the sealing. And here we use a high frequency, low voltage current, and that will cause lineage of the elastin and collagen in the vessel wall. So that will result in the formation of the coagulum, and mechanical pressure make the denatured proteins to make a coagulum. And apart from that, those instruments have the sensors at the tip of the instrument which will measure the tissue impedance, and then the energy delivery is automatically discontinued when there's a proper coagulum form. And then the tissue is divided by the mechanical cutting system. Moving into the ultrasonic devices, the common one we use is this harmonic scalpel, and apart from that, this sonicization also there we haven't commonly encountered. So here, those devices use this electrical energy, and which will transformed into ultra high frequency mechanical energy. So heat usually generated by the mechanical energy and causing denaturation and the formation of coagulum. So here, initially those devices able to seal blood vessel up to about 5 millimeter inside, but now newer devices also can go up to 7 millimeter size blood vessels. And then after making this coagulum, the tissue cutting could be done in two mechanisms. One would be this heat produced by the blade, and other one would be this power generated by the vibration causing the stretching. When we further talk about this harmonic scalpel, so it came with this two exclusion range, so maximum and minimum range. So in the maximum setting, so there they apply this rapid cutting of tissue with minimal hemostasis capability, and in the minimal setting, so there will be a less efficient cutting, but greater thermal damage and better hemostasis would be there. So if our aim is to do the hemostasis, we need to activate the minimum set. And when compared this Sony session, it is a manufactured different harmonic ultrasound device. So it says that it is a cordless ultrasound device that will give more freedom and maneuver for the surgeon. Apart from that, there are this laparoscopic dissection by torsional ultrasound, which will reduce this distal wean effect by due to this conventional longitudinal compression forces applied by the harmonic device. When considered combined energy devices, so common one is this Thunderbeat by Olympus Japan. So here they use this both ultrasonic and bipolar energy. So usually there are two modes. One is seal and cut mode, where ultrasonic generated energy and electrical generated bipolar energies simultaneously delivered to the tissue. But in the seal mode, they deliver purely the bipolar energy for vessel sealing. This also has these sensors to identify the tissue impedance and the automatic stop of the device. There are a few studies and they demonstrate that all those high energy devices are equal in efficacy, but the choice would be dependent on the availability, cost, availability, preference, and as well as the cost. So those are my references, and I will conclude my presentation, and thank you.
Thank you very much, Shavinder. That is very excellent presentation. I think it's very educative as well. So without further delay, let me invite our resource persons to comment and ask further questions. Neville sir and Manjula sir.
What are the advantages and disadvantages of bipolar versus monopolar diathermy used in transurethral resections?
Yes, this
Yeah.
in the TURP, this TURP is this what the emergent data suggests that this bipolar would increase the coagulate, this hemostasis effect, and also with this bipolar diathermy we can shift our irrigation fluid into this more physiological saline. So this TUR syndrome is very less, and but cutting property would be very less with the bipolar than the monopolar. So, and apart from that, this in the bipolar, the returning electrode would be this outer sheath. So theoretically, there is some increased risk of having urethral stricture following the procedure of bipolar TURP. And those are some pros and cons when using the bipolar side.
Yeah, basically, I think that what the systems we are using is called pseudo bipolar, because real
Yes,
bipolar is ACME and Karlstorff's productions are there, which are true bipolar, which uses the two the arms of the electrode as returning electrode and the other one. But the Olympus system is a pseudo bipolar where the return is done by the sheath. But I think there is no evidence to show that this increased amount of number of strictures. Initially, there was a concern whether there are going to be high number of strictures. So that's one thing. And then, as you said, the bipolar, will it completely eliminate TURP syndrome?
No, sir, that it won't eliminate the TURP syndrome, but it will eliminate this dilutional hyponatremia component of the TUR syndrome. Other part would be there with this hypovolemia and the electric disturbance.
Yes. Yes. So the rules still apply that the resection time should be 90 minutes or less, because the overload part is not eliminated. Only the hemolysis and hyponatremia is can be eliminated to a certain extent. So it is not entirely safe. So that's the something about the bipolar system. And the bipolar system mechanism, do you have any idea how does it, is it just straightforward bipolar diathermy in surface surgery?
No, so that will
Or the mechanism is different?
vaporization and explosion of the,
yeah,
exactly, remember
the
that.
formation of plasma sphere, you know, the mechanism is slightly, yes, so you better know that. And then the use of mushroom diathermy is specific for bipolar diathermy. Have you have you come across the mushroom electrode, or what we call mushroom electrode is for, that's a specific feature of bipolar diathemy where you can evaporate tissue. So small prostates, you can complete, there won't be any tissues available. It has a similar effect like laser, where the tissue disintegration will take place, and then you can evaporate the tissues. It's not generally found in monopolar systems. So anything to add?
So I think the mushroom has a higher risk of bladder neck stenosis, and because of the higher usage of
Yes.
cauterization.
Close to the opening, no?
Yeah, the conventional bipolar compared to.
Yeah. So I don't know whether there's another disadvantage I see with the bipolar is that the loop size. Loop size is quite relatively small compared to size 24 monopolar. So the specimen sizes or chip sizes are a little less. So that is one little relative disadvantage. But otherwise, I think more or less it's this DRP syndrome that you have to concentrate about when you're using monopolar. But I don't know whether you all agree, but I think the future lies with bipolar system, because for small prostates, you can use mushroom to evaporate. Medium-sized prostates, you can do resection. And the larger prostates with the bipolar, you can do the endoenucleation. Though some people say that they will use water or glycine for endoenucleation with monopolar, I think there aren't very many studies regarding endoenucleation. When it comes to endoenucleation, most of the studies are done with bipolar. So bipolar has the advantage of using it in different techniques for any size of the prostate. So I think if you are in future, I think if you are investing money on a resectoscope, I think must go for a bipolar.
So whether there's any study,
yeah,
any study showing that because of a bladder tumor, they're doing monopolar advantage that it can cause cell lysis and protein cells. Any studies
you mean
compared with
the
bipolar?
studies are there are a number of studies. Yeah, I did a lecture on this. There was actually a debate on bipolar versus monopolar, and there are a number of studies to show that the advantages of bipolar. But those are none of those are large-scale studies or meta-analysis, except for the elimination of TURP syndrome. The advantages are not very clear. The other mechanical advantages, but there are a number of studies now. Yeah, bladder tumor, when it comes, of course, there is no difference. No difference, because bladder is being a unabsorptive surface. I don't think there are any. I have not come across any reasonable studies to show that there's a difference between these two. Whether you are doing standard resection or on-block resection, these both monopolar and bipolar will probably have the same outcome. Do you have any comments on that, Manika? Do you have come across any studies?
No, sir. I just asked.
Yeah. I think when it comes to bladder tumor, we are not bothered too much about monopolar or bipolar because of the non-absorbing surface.
And the tarring and sharp cutting.
Yeah,
monopolar sometimes it's difficult to cut when there's a charring, because when you diatomize that area, it's difficult to cut. But bipolar, that advantage, whatever they are, you can cut. Even the fine cuts.
Slight advantage I can think of is that if you are doing a large tumor, especially dome, and then you make a big perforation, I think the peritoneum get flooded with water. You're using water. I think there is a higher chance of water absorption syndromes compared to. So that is only when you are doing large dome bladder tumors. That's a practical advantage of using bipolar with saline.
Okay, shall we move to the next topic? Or
yeah, one more question. I think it was asked at one of the exams. What is the ideal diathermy pad size? Dr. Alahakon, The one,
Yes.
yeah. Ideal surface area of the diathermy pad.
It's I'm not
You
very
come
much,
across that,
but
yeah.
I heard that is
There are
about
various sizes,
80
70 square centimeters.
square centimeters.
Something like that, you check that because they are very particular about it. You said that the pediatric people have smaller sizes. That's true. Other thing is, another advantage you can mention about bipolar is that you can use it with the presence of cardiac pacemakers. But nowadays, there are new cardiac pacemakers which are not sensitive to diathermy current. But generally, if you have an older cardiac pacemaker, bipolar resection will be always safer. Or else you have to place the base plate away from the path of the current if you are using monopolar. So that is a basic principle of. And what about the obturator jerk? Is there advantage over bipolar or monopolar when you are eliminating the obturator jerk when you are cutting lateral wall tubes?
With the bipolar, this obturator jerk is lesser, but it is not totally eliminated.
Right. So initially, this bipolar diathermy was invented to get rid of obturator jerk. So that was the initial idea. But other advantages of absorption syndromes were there. So, but unfortunately, still, if it is very close to the operator, still there can be some sort of a transmitted current which can cause operator jerk.
Can you tell that anyway, if there's a lateral wall tumor with patient with a very high comorbidities, how do you can deal with that if you can't give GA?
We can give obturator nerve block.
Yeah, that is now I mean, more and more people practicing now that, no?
Yeah, so you all have to be a little conversant with how to do it in a male. Female is, of course, it's very easy to put the finger into the vagina and then feel the ischial spine and you infiltrate parallel to that around the ischial spine. But male, you have to do a DRE and then direct the needle to the necessary area. So if you are doing it on your own, the anesthetist is also not conversant with giving the obturator block, pudendal block or obturator block, obturator block. You should know the technique. So sometimes we have to do it ourselves, if the anesthetist is not very familiar with the thing. That's the only way to stop it, or else you have to give a muscle relaxant. Spinal anesthesia, as you know, will not stop obturator jerk. Yeah, we can move on to the other one. Or,
Yes,
are there any
I
other
think-
questions? Yeah.
I think we are running a little short, and probably better to move to the next topic, sir.
Yeah. Okay, sure.
Yeah, and also Dr. Mahendra here won't be available. He is unavailable reasons. So I think we can discuss two other
All right,
topics,
okay.
scopes and the indoor.
Yeah.
So shall I move to the next one, Nishanta? No, sure. Can
we can? Yeah, we can move
we
to
can,
the
no?
scopes and sterilization.
If we have more time, then we can discuss about how many can other advanced energy devices after that as well. Okay, so let's move on to the next topic for today, scopes and sterilization. And this will be presented by Dr. Malakrishnan Pragalathan. And Dr. Pragalathan, you have 20 minutes. Over to you.
Yes, so good evening to you all. Today I'm going to talk on the telescopes. I think in the telescope and something about the sterilization. In the telescopes, I'm talking about the architecture of the telescopes and the some internals of endourology in the telescopes, as well as the lighting and the some commonly used regarding the some commonly used scopes in the urology, and finally the sterilization. The telescopes, the history that Hans Lippershey found that endoscopy is in the 16th century. Then the Philips Bosnis that developed the first modern endoscope in 1806. Then the Max Nitz, the German urologist, credited with the invention of the modern cystoscope in 1879. Then the French urologist Antonin Jean introduced a smaller profile endoscope in 1953. So until that, previously that was used as a diagnostic one. From this one only, they started the therapeutic as well. Then Harold Hopkins developed his lens system in 1959. Then the Karl Storz brought the patent and began to produce the endoscopic instruments in the 1967. Then Marshall reported the first application of flexible gyrotoscopy. Then the Boyle and Smith developed the charge coupled device in 1970. From this on, that digital endoscopes developed. The telescopes, the optical instruments for making distant object appear larger and the nearer. The different types of telescopes used in the urology are the cystoscopy and the cystourethroskop and the ureteroscope and the nephroscopes and the laparoscopes. They are rigid, the semi-rigid and the flexible. The architect of the telescopes, it's containing the two main parts, that eyepiece as well as the outer tube. In the eyepiece, it's containing the eye shield and the light post, and the outer sheet which carry the optic carrier tube and the illumination fiber. Then the lens system and the distal end of these telescopes, which carries the prism, which will create the angle of view. So when the compare this Hopkins slot lens system versus the conventional lens system, the traditional telescopes lens system having a tiny lens, so which need the when we need to arrange the lens system in a position, so need more wider outer tube, so which leads to the less field of visions as well as the large scope size. But in the rod lens system, it carries the very rod lens, so which can easily position it. We can easily arrange in that position, so we can use the smaller diameter, so which improve the resolution and the contrast and the brightness, and also having a more field of vision. So when considering the angle of view, that so the distal end of the telescope which carries the prism, so which can create the reflection and create the angle of view. So usually that 0 to 12 degree, it's for the best visualization of the urethra, which can coded by green code. Then the 25 to 30 degrees are commonly used for the therapeutic purpose for the resectoscopes, which coded by red in color. Then the 70 or more 120 degree, which can't use for the resection, so but it can only use for a therapeutic purpose. So mainly they inspect the anterior and diagnostic purpose, mainly inspect the anterior and the infralateral walls, dome and the neck of the blood. So in the internals of endoscopes, mainly the flexible scopes, they're available in the fiber optic and the digital ones. The digital scopes do not require the focusing of white balancing. But in the fiber optic scopes need a white balance because it carries the white from the halogens light. They're available in the, but these are available in the high definition and the standard definition. So these are the low one is the normal standard, the fiber optic endoscope, which needs the camera cable as well as the light source separately. But in the digital one, which carries the camera as well as the light source through the single cable. So the digital endoscopes, which having that charge coupled device and the CMOS chip at the digital end and the working channel, the light guide fibers and the angulation wire. So when the digital scopes, which carries from the objective lens, which creates the photons, convert the photons to the electron, which from the charge coupled device, which carries through the wires to convert to the monitor to create the real-time image. So the two different imaging chips are used in a digital flexible gyrotoscope, such as the charge coupled device and the complementary metal oxide semiconductors. And they are converting the photons into the electrons and wires within the gyrotoscope that carry the digital signal to the image process, which then converted into the image for the real-time view. The digital scopes created the higher for the both maneuverability and the visibility. So this is the clarity of difference between the fiber optic as well as the digital one. The upper one which shows that fiber optic one, which the each and every fiber is creating that the honeycomb appearance, but in the lower one, the digital one with the high clarity. So the video endoscopy system, which consists of the light source, endoscope camera, image processor, recorder, and the monitor. And advantages of endoscopy system that having the better visualization, enhance the patient safety and surgical training, the decrease the risk of bodily fluid exposure, and the improve surgical surgeon's economics. Fiber optic light bundle, so the flexible transparent fiber made by drawing glass, the silica or the sometimes with the plastic tube diameter is so diameter slightly thicker than that of the human hair. Transmit the light between the two ends of the fiber. When we are cutting cross section of this fiber, which can source the outer the transparent cladding material with the index low index refraction. The core, the optic fibers typically included the core. Light source, the high intensity xenon or the halogen external light source, and the delivers white light through the fiber optic cable and the endoscope to the field of view. So integrated some digital endoscopy having with the LED illumination. The narrowband image that utilize only the blue and the green wavelengths to image the urothelium. The photodynamic units which used to the daylight system with the blue light filter. The cystoscope, the rigid cystourethoscope, the sets consisting of optical lens and the bridge sheath and the operator. The bridge connects the optical lens to the sheath. It can available in the diagnostic as well as the therapeutic bridges. Usually the therapeutic bridges having the double bridge. That's Auburn bridge, which is found at the distal end of the telescope scopes, which guide the guide wire to where the difficult cannulation to the ureteric orifices with the high blood and echo with the larger median lobe of the prostate. These are the different types of the cystourethoscope available in our practice. With the Karl Strauss, the Olympus, and the Gyrus as the valve. The lenses from the ranges from 0 to 120 degree with the usual working length is about 30 centimeter. And the bridges, it's having the diagnostic as well as single and the dual channel. Then working sheath, which range from the 17 French to the 25 French. In the flexible cystoscope, that ranges between the 16 and the 17 French gauge, and the models differ with the regard to the tip deflection and the direction of view, and the working channel size, illumination, and the optics. Mostly the field of view approximately about 120 degrees, and the tip of deflection ranges from the 120 to 220 degrees, 210 degrees in a single plane, and the irrigation and the instrument passes through the same working channel. Available in the fiber optic and the digital models, and also available in the high definition and the standard definition. Again, that there are various types of flexible cystoscopy from the Karl Strauss and the Olympus and the Wolf. So it's the working length range from the 37 to 40 centimeter with the shaft diameter from the 15 French to the 16.5 French. And the ureteroscopes are which are available in the rigid and the semi-rigid and the flexible. And the rigid one with the rod and lens system, and the semi-rigid and the flexible one with the fiber optic and the digitals. The advantage of semi-rigid ureteroscope is compared to the others with smaller diameters and the less chromatic and require the ureteral dilatation less often. And the semi-rigid ureteroscopes with the eyepiece available in the eyepiece available in the two patterns, with the inline and the offset. With the inline, that it's having the working channel in a angulation, so we can't use this the rigid instruments through that. For example, that the pneumatic lithotripsy for the stone fragmentation, or with the rigid biopsy forceps can't do this with the inline. But with the offset, we can use these rigid instruments. The most have a tip of diameter of 7 French gauge, and the working channels with the large single and the two small individual. With the two working channels having advantage of we can use with the irrigation, continuous irrigation, while inserting that working instruments through the other channel, and also with the for the lithotripsy we can use the basket to hold the stones to prevent the retropulsion during the laser lithotripsy. Then the flexible ureteroscopes with the available in the fiber optic and the digital ones, with the digital one having the charge coupled device as the same as, and the digital camera and the light source within the scope. The modern flexible ureteroscopes allow the both up and down deflection in a single plane, with the active deflection with about 270 degree. So with the most of the time with this active deflection, we can enter into the lower calyx. So to enter into the lower calyx, we may use the passive secondary deflection while using this the medial border of the renal pelvis to create the more secondary active passive reflection. The Karl Strauss, which created this with sometimes with this the large wider pelvis, we can use this with the secondary passive reflection also we can sometimes be difficult to enter into the lower calyx. So the Karlsruhe we created the more exaggerated deflection to about 360 degrees. Then the nephroscopes with the having the parallel eyepiece with the angle eyepiece from the 24 to 26 front case operating sheath. It's about usually the 25 to 90 centimeter length with the 13.7 French case working channel. Then the resectoscope, the standard one from the 24 to 28 French case with the extra long with the 26 French case and the slender with the 22 French case, and resectoscope is having that usually the 20 centimeter long from 24 to 28 French case. The urethrotom, the optical urethrotom, the 21 French case to with the 20 centimeter long with the some with Otis urethrotom. Then I move to the decontamination of the surgical instruments. The decontamination defined by the reduction and or the elimination of the microorganism from the medical devices or surface of the environment, such that they cannot reach the vulnerable size to cause the infection. The reusable surgical instruments that have the potential to provide a route of transmission of microorganism between the patient. So any decontamination process should not cause the harm to the patient or the staff. The recently the published WHO guidelines specifically pertaining to the decontamination of the medical devices. So with the so we can classify the medical equipment according to the risk of infection with the from the high risk, intermediate risk, and the minimal risk. So the minimal risk, the which are instruments used in a intact skin, such as the bladder cuff, the pressure cuff, as well as the stethoscope. We can use this just cleaning to cleaning for this. And the intermediate one, where the instruments which are used in a intact mucosa or with the non-intact skin, such as the anesthetic equipment, the endoscopes and the laryngoscope. We can use the high-level disinfection with the chemical disinfection. The critical items such as that the instruments which are contact with the sterile area or with the blood, such as the surgical instruments, need the sterilization. The cleaning is the physical removal of foreign materials such as the dirt, grease, or the organic matter. They usually performed using a water with the detergent or the enzymatic products to remove the soil. The manual using friction and the fluidics or the mechanical using ultrasonic cleaners or versus the disinfectors. The cleaning agents properties having the saponification, emulsification, the surfactation, the dispersion, appreciation, and the water softening in the pre-rinsing and the non-toxicity. They are essential for any device prior to the disinfection and or the sterilization. The disinfection, so the reducing the microorganism to the non-pathological level in inanimate object or the surgical instrument, except the bacterial spore and prions. The physical disinfection with the moist saturated steam at 73 degrees Celsius for 15 minutes at subatmospheric pressure, usually with the wet for the wet pants, journals, linen. The boiling, or we can use the boiling water for 100 degrees Celsius for 5 minutes. And the chemical disinfection with the sodium hypochlorite, with the alcohol, glutaldehyde. So with the problems with the glutaldehyde, so vapors can cause the respiratory irritation as well as can cause the allergic contact dermatitis. And the coagulates the blood and fixes the tissue to the surface. Then the sterilization. Complete removal of all viable forms of organism, including the virus, bacterial spores, and mycobacteria to the non-existent levels on inanimate objects. So we can divide it into the according to the instruments capability to the heat tolerant as well as the moist tolerant. If the instruments with the heat tolerant with the moisture tolerant, we can use the autoclave. If the instruments not heat tolerant but heat tolerant but not moisture intolerant, we can use the dry heat. If the instruments are intolerant to the heat but moisture tolerant, we can use the chemical sterilization with the parasitic acid as glutaldehyde. With the if instruments are not intolerant to the heat as well as moisture, so we can use the ethylene oxide or H2S2 gas plasma. These are the common methods of used sterilization. One is a steam, and the hydrogen peroxide gas plasma and the liquid chemical sterilization with the acetic acid and the glutaldehyde and the dry heat. The sterilization of the on the urological instruments, the sterilization of the ureteroscopes can be performed by using a gas, ethylene oxide, or the soaking in a glutaldehyde solution, or using the sterile system. The rigid cystoscope and the rigid and the semi-rigid ureteroscopes are even autoclavable.
Thank you for the very comprehensive presentation, Prahladan. I think resource person can ask questions. Over to Nevisa and Manjula.
Yeah. What are the steps you can take to prevent inadvertent damage of urological endoscopes? Inadvertent injury, apart from during surgery, the mechanical problems. What are the common causes of damaging the endoscopes?
Actually, the proper training to the
as you know, these are expensive. Yeah.
Yes, the proper training of the staffs who are handling these instruments.
Yeah. How can the sterilization damage the endoscopes? How do you know that the endoscopes, especially the flexible scopes, are damaged?
So the most of the time they are while using this, they are bending the scopes. So while using this sterilization.
And what is water invasion? Have you heard about water invasion and testing? So there is this sheath, the polyvinyl sheath around the fiber optic scopes, and any damage to the sheath by over deflection or sometimes the laser injury, and sometimes over the edge of the sheath, access sheaths. When you have a minor injury, then when you are doing submersion, sterilization, the fluid can invade the inner system. It's called water invasion. And there is this, engineers have a way of testing for water invasion. So that is the common way of damage, fading. And also if you start seeing dots all over the place, that means the fibers are individually damaged. But if the overall vision becomes ground glass-like, that is what we call water invasion, and it's very difficult to repair that sort of a thing. So that is one way of sterilization. Another thing is handling. That one of the common causes are that the storing the flexible scopes and closing the lid. During closing the lids of the sterilization trays, they used to catch the tip of the or part of the fine ureteroscopes. So the handling. What is your idea about any other way of, as you know, ureteroscopes are the things we are most concerned about because they are expensive, and it has been shown that, you know, when multiple users, multiple surgeons are using it, the guarantee is there for only for first 20 to 50 procedures, and after that, invariably, there will be either minor or a major injury damage to the ureteroscope, flexible ureteroscope. So, so that's why this, I don't know if you have come across it, the disposable ureteroscopes have come to the scene.
Single use.
Have you seen disposable ureteroscopes?
No.
Yes?
No.
All right. It's there now. It's there in use. I think it's quite kind of economical thing when you think about it, because ureteroscope is about 10 to 12 million now. So repairing costs are also high. So disposable scopes are now available, and you can buy the processor and the scopes, 10 scopes for 3.5 million. And each scope is supposed to be disposed or taken, thrown out after the first procedure. But generally, we can do about 10 to 15 procedures per scope, disposable scope. So nothing is disposable in the country, you know that, except toilet paper. So, so when you think of the cost effectiveness, these disposable flexible ureteroscopes are becoming now more cost effective and user friendly. And those are the vision is because it's a chip on the tip type of scopes, sterilization is necessary for if you are reusing it, but otherwise sterilization is also not necessary if you use one scope per patient. Just know about this current development in flexible ureteroscopes. Manjuli, there is anything to add about last questions? Yeah, I think we can, in the absence of any questions, what about the organizing panel?
Yes, sir.
Clarify,
Yeah. Manjula, I think Manjula sir is not there.
Right. Okay. Yeah. The audience is going down. Ultimately, I think only very few of us will be remaining there to conclude this meeting. So, should we move?
I think, shall we move on, sir? We can. Next presentation is by Dr. Divika on endourology and its accessories for 15 minutes. Divika, over to you.
Yeah, yeah, I'm going to talk about endourology accessories. Here, basically, I will be talking about the accessories used in ureteroscopy and during the PCNL procedure. So we have so many accessories. So first, I will be starting with the baskets. So basket, as we know, we are talking. The property is to open with the enough radial force in the ureter and to capture and disengage a stone. So it comes in various sizes. Smaller the diameter. Smaller the diameter because the working we are inserting the basket through the working channel. If it is the basket, if the diameter is small, then we will have a good irrigation fluid flow, and also will allow simultaneous laser fiber insertion. That is called side by side approach. And also it will also allow greater scope deflection in flexible URS. But because of due to the repetitive insertion, the durability can be less. So we have various designs. It can be tipped or less tipless. The old Domia baskets were reusable. It was made of stainless steel, but nowadays nowadays baskets are made of retinol material. Retinol material is a mixed composition between the titanium and the nickel, which allows a surgeon to be less traumatic and more efficient during the stone retrieval. And all of them are single use, but with the comes with different shapes and designs. So we have in the market, we have tip basket, tipless basket, and basket with the special designs. And uh, so the tip basket is the one you can see with a helical shape that is made of stainless steel tipped at the end of the basket. So they have high radial dilatation, radial strength, and rigidity. But the problem with the tip, it can cause ureteric or renal papilla injury. So that is not to be used to remove the stone from the renal pelvics. And also tip also can cause bleeding from the mucosa, which can cause problem with the visualization. The tipless baskets, that is a new generation, that is made of nitinol device, retinol material. So that has a good dilatation force, kink resistant, and memory properties. Again, the configurations can be helical, can be spherical, or can be N-cage design. The helical design already, with the helical design, it has a tip with a stainless steel, and so it is not to be used in the pelvic stone removal, but it causes, the advantages are it causes less ureteric mucosal entrapment, but has more difficulty in engaging the small stone. So not suited. The spherical ones, again, overall it has a good dilatational force, so easier to capture stone in the kidney. But the problem is we can't extract multiple stones at once. And the N-cage design when we open the N-cage design, it releases like a three-prong grasper. So we can capture more stones, and also the different to other grasper, we can catch the stone from the front view. So if the stone is impacted with the ureter mucosa where we will not have enough space, we can use this kind of grasper. And also because of the wet design, it can capture the small stones as well. So these are the various designs. The complications, coming to the complications, the main complication is a ureteric injury. So ureteric injury happens when we capture the large stones or when we capture the multiple stones. So to prevent this ureteric injury, there are specially designed types are available. So something called escape basket. So when initially it has a 4 wire. So when we want, if we want to release the stone, it will transform to 2 wires. And there's a halo rotatory wheel, so it can increase the basket size. Then the dimension, there's a dimension. This is the brand names. There's dimension. It has a turning wheel to increase the basket size. So these are the modified baskets to encounter this problem. If we need to solve this problem, if we encounter. And stone extractions are done for the stones less than 6 millimeter. If it is more than that, there will be a risk of ureteric injury. Then coming to the guide wire. So guide wire is to provide safe access to the renal calyx. And to be an inner portion of the coaxial system for passage of other instruments. The properties are strength. The strength is important and it has 2 layers. The inner layer and the outer layer. Inner layer is the one which determines the rigidity. Outer layer will provides lubrication. The rigidity, again, the older generations are made of stainless steel. The newer generations are made of nitinol. And we have various sizes ranging from 0.018 to 0.038. And the length is, commonly used length is 150 centimeter. Again, we have various types. It can be straight, it can be angle, it can be J-type. The J-type is the one which is used for the PCNL, and the angle type is better if the ureteric orifices is more laterally placed. And then we have the surface coated ones. It can be PTF coated or hydrophilic polymers coated. Then there's something called hybrid hide wire, where the distal end of the hide wire is made of hydrophilic material. That is used when we have difficult access, if there's a stenosis, stricture, or if there's an impacted stone. The uses are again instrument insertion, stentor or URS, or ureteral access, retrograde pylography, and ureteric dilatation. So these are then coming to the ureteral access sheath. So ureteral access sheath, this is important when it comes to flexible URS. Again, this instrument designed in a way to straighten the ureter and facilitate the insertion of flexible URS. It has 2 parts, inner obturator and outer sheath. Inner taper dilator, the inner taper dilator tip can also be used as a ureteric dilator. The outer surface is coated with the hydrophilic substances to facilitate the entry. The advantages are because it straightens the ureter and it keeps the flexible URS in position. It decreases the intrapelvic pressure, improves the irrigation flow and the visibility, and decrease the need to empty the bladder, decreasing the operative time and facilitating the ureteral re-entry, and also protects the ureteroscope. Again, so success rate of the success rate of ureteral URS insertion depends on if the ureter is dilated. So we can go for a pre-operative stenting at least 5 days before the flexible URS insertion. And old age also, because ureters are dilated, the success rate can be the more. And if there's a history of prior endoscopic ureteral surgery and smaller stone burden, again success rate will be high. The complications are because if we are using a larger diameter, it can cause ureteric ischemia and stricture. Then we have anti-tetrapulsion device, as Manjula sir mentioned before, during the ureteroscopy, because there's a risk of tetrapulsion about 5 to 40%. To prevent the tetrapulsation, we have to take some maneuvers, and with that we have some devices. It can be mechanical wire basket or mechanical balloon basket to prevent the tetrapulsion, and it can also be used as a thrown retrieval devices. Then we are coming to the puncture needle. So puncture needle mainly used in PCNL. So we have puncture needle with a two parts pieces. In the central part is a sharp one central mantle and the outer sheath. And the central part is it's elongated than the outer sheath. And again, outer part is at the tip there's a sharp cut straight edge to prevent the damage when we are withdrawing the sharp edge, sharp inner part to prevent the geometric damage. The outer part, the end of the outer sheath is straight cut. And so we have various needle sizes varying from 18 to 21. When we are using if we are using the larger one, we can put the normal guide wire. That is a 0.038. And but the advantage of having a smaller needle, we can negotiate the undilated calcium infundibulum, and again less traumatic. But if we encounter the rigid, if we encounter rigid area or a fibrous area, better to use the larger guide wire, larger needle. And then we have the other devices used for tract dilatation. So tract dilatation, it can be temporary or permanent. It can be used before the PCNL procedure. It can be used before the PCN insertion. Nephrostomy insertion. The fascial dilators, again, we have various sizes, and so usually they are flexible devices. So after putting a guide wire, we are inserting this fascial dilator. The problem with the fascial dilator, because it's flexible, sometimes the guide wire can get coiled in the perinephric fat with a loss of drag. And because of the compressive forces, there can be undetected parenchymal vessel bleeding. And again, the disadvantages is because it's flexible. Sometimes it's difficult to dilate the fibrosed area. Then we have the alkane metallic dilators. So this is again commonly used in PCNL. It's metallic splinters, and we have increased various sizes with increasing caliber by 2 French, and these are axially loaded over the rod. So, and it is arranged in a way when all are connected, it will not bias. It will not go beyond the rod. Then we have the umbrella dilators. It's again like a alkane dilators, it's made of plastic dilators. Then we have balloon dilator devices, but we are not using it commonly. And these are like the same principle as angiographic intervention. We can use the balloon dilator system, but the problem with the advantage is when we are using the balloon dilator, the force is radial, so less traumatic to the tissue. And again, theoretically there's a low risk of tissue damage and bleeding. The disadvantage is we might not be able to get a satisfactory dilatation because of the balloon dilatation. And again, it is difficult if there's a dense connective tissue or cicatrical tissue. Then coming to the umbrella sheath. So umbrella sheath is made of plastic or Teflon cylinder, and it is used to maintain the percutaneous tract during the intervention. And if we want to go for re-access and allowing easy re-access, and it prevents leakage, allows evacuation of excess irrigation fluid, and also evacuation of fragmented stones. And during the procedure, it compresses the blood vessels so that the bleeding into the tract will be minimal, and also it prevents the migration of the stones into the perinephric fat. So it can be radio opaque or it can be radio transparent. The big advantage of having radio transparent, we can when we are using CM, we can detect the stones, the dense stones. And because it's oblique, by rotating this oblique, we can see if there's any undetected hidden stones. We can rotate the sheath and see whether there are whether we have missed any stones. Then coming to the lithotripsy devices. So we have various lithotripsy devices ranging from a pneumatic laser and other hydraulic. And the principle of pneumatic lithotripsy, it is the old generation wise, the first to be inverted. And so it has the mechanism is it has there's a pressurized system in the handle. When the pressurized is transmitted to it's propelled to the metallic probe, and it will give the pressure of 3 atm and frequency of 12 hertz, and that will be transmitted to the directly to the stone, and it can cause mechanical energy. So we need to have a direct contact with the stone, and this is the pneumatic lithotripter. So by direct contact with the stone, we can increase the performance. And again, the advantages is less costly, efficient, and the heat is not generated during the procedure. Disadvantage is because it's rigid, it cannot be used in the flexible nephroscope. Then ultrasonic lithotripsy. So ultrasonic lithotripsy is using the ultrasonic waves which are created using the piezoelectric crystals under the action of electric current. So these frequencies far beyond the normal audible spectrum. It's about 23 kilohertz to 25 kilohertz. So again, the ultrasound waves can cause, it can create vibrations. This vibrational energy will be converted to mechanical energy to fragment the stone. So the main problem with the laser, it can cause we need to have a continuous irrigation, because it can cause overheating and damage to the instrument, damage to the adjacent structures. And so we have the combined pneumatic and the ultrasonic lithotripsy. We through the same central unit, we can use both simultaneously to fragment the stone. Then we had the electrohydrogenic lithotripsy. There we have the other stone for the other mechanism. The energy comes from the electrical charge in the liquid medium. So it's like a shockwave lithotripsy, ESWL same mechanism. The cavitational bubbles are formed, and that will cause a shockwave lithotripsy to fragment the stones. Then finally we have the most the efficient and the commonly used one, laser lithotripsy. And the laser is the holmium laser. We have about 2100 nanometer wavelength it has, and the fiber ranges from 200 to 1000. So it's more efficient in the fragmentation, is dusting, fragmentation, popcorning, everything possible. The risk of perforation is less, but is still higher than pneumatic and ultrasonic. And there's no photoacoustic effect, so there's low risk of bleeding. And during the and we had to know that during the fragmentation, we had to keep the tip of the laser at least 2 millimeter away from the nephroscope end to avoid damaging the optical system. And then we have for the PCNL procedure, we have various extraction devices. So we have alligator forceps, tripod, and the smooth grasper. Alligator forceps, it has a jaw profile, but need to have there's a jaw mechanism, but we need to have a good space to work, to open the jaws and to grasp the stone. And then we have the tripod grasper. It has a good grasp, but it can easily perforate the pelvic calcium system. So coming to stents. So stents are commonly used accessories. Ureteral stents typically range from 4 to 7 French in diameter. They are made of flexible polymers. It can be a polyurethane or silicone. And we have the double J stenting, pigtail stenting, and the single J stenting. And we have open-ended spiral tips and whistle tips. And so it is again commonly, it can be inserted as a therapeutic or prophylactic. So when there's an extensive ureteric compression, the metallic stents are more commonly used, and it has a patency about 50%. But because of the hyperplastic tissue reaction, incrustation, tissue ingrowth, these are the complications, and it can also cause ureteroiliac fistula. And the other problem is the stent morbidity. When there's an indwelling stent, it can cause significant urinary urgency, frequency, and the stent-related complications. And we can it can be managed with alpha blockers and antimuscarinic. And to minimize the blood irritation symptom, there are specifically designed stents also available. The nephrostomy tube, again, so it's commonly used after the PCNL procedure, uh, and it's also can be used as a therapeutic intervention in when there's infected obstetric system. And tubes have it can permeable and impermeable distal ends are there, and the perforation near the distal end, there's no perforation that will show that there won't be any urinary leak. And so after the procedure, we had to select the nephrostomy tube to match the dilated tract. So, so it can serve it can serve as a hemostatic agent also.
Thanks a lot, Devika, for the comprehensive presentation. You have managed the time well, even though your presentation is big. We can go for the questions from the expert panel. Over to Neville sir and Manjula sir.
Yeah, you mentioned about the, this is a very sort of wide area you covered, I think very nicely covered, nice review. What are the other disadvantages of J stents? What are the problems of leaving a J stent? You mentioned few complications.
Encrustation.
What bothers? Yeah. Okay. Long-term encrustation. And what is?
So
You
again,
said the
it's a
blood
foreign body
irritation leading to. Yeah. So, and this is the ureteric reflux. Get vesicular reflux because it makes the uretrovesical junction incompetent. So that people, when they are passing urine, they complain of, some people complain of discomfort in the loin discomfort. So, especially when the bladder is full. That's one thing, and the trigonal irritation, and long-term encrustation, and so those complications you have to be aware of. And what about the long-term ureteric stents? If you want to leave your ureteric stent for a longer period,
there are
you
specifically
have
this
these,
metal stent, and there's a combination of the coated nitinol and titanium.
Yes, and also annual stents. You know, you can, the higher silicon percentage is there, and you can leave it for about an year. So the lifespan for stent is generally about 6 months maximally. That is what the manufacturers advise. As regarding stents, yeah.
You might need to know about how to manage with encrusted stents.
Yes.
They might ask.
Yeah. Yes, any idea? You can summarize in a minute how to manage a forgotten stents. Those are called collectively forgotten stents. There are published articles in local journals also about forgotten stents. Sometimes stents are put and people forget to remove it, and then you get severe incrustation. As Manjula asked, how do you manage them?
So first we have to evaluate the patient properly with the imaging, and to see the extent of the encrustation, and see whether the patient is active at the moment, whether the patient is having any active infection, and whether there is any associated other stones with the encrustation. So ideally we had to go for a CT urogram. Then after that, depending on the extent of the encrustation, we have to plan the procedure. So if it is depending on the extent, we can if it is lower part is encrusted, we can go for a URS and laser and remove the stent. Or if it is upper part, then we might have to go for PCNL, combination of PCNL and the URS at the same time. So we can be, if it is severe, even we can go for a stepwise process, stepwise management if it is severely extensive. And we had to assess the renal function also. So if the renal function is if it is a bilaterally affected system or single functioning kidney, then we had to go for urgent PC, to protect the kidney until the definitive procedure is done. And then
Is there a place for shockwave lithotripsy? ESW?
So
There's
there
an
are so
article
considering
published, yes. Yeah, upper coil encastrations, shockwave lithotripsy, because these are low density encastrations. Sometimes ESWL in a localized area, if you can't straighten the upper coil, you can double stent him and then put another new stent parallel, and then shockwave lithotripsy also might be helpful. Rather than all the others are invasive procedures. So you might try the upper coil ESWL, and sometimes when it become de-encrustated, then you can pull the thing from down.
Another thing, you should
Otherwise,
not pull
ureteroscopy.
it.
Yeah.
You should
Yeah,
not pull
yeah.
because you might have a ureter.
Yes.
And the bladder,
And
you can deal with the stone puncture or even the laser or in the IPL bladder
correct.
part.
Yes.
Yeah. So bladder part,
no.
ureteric part, and the renal part.
Yes.
3 components you have to deal separately.
Yes.
Separate
And
mean the separate measures.
always do it under CM guidance
Yeah.
throughout the procedure in between under CM guidance. Then about anything else to ask? Almost everything covered, isn't it?
Yeah.
And also about the sheet before doing the flexible URS.
The baskets, you own with a basket, and then stone would have anyway come out. So when you're fragmenting, do you have to remove all the fragments? What is your view about, suppose once you
no.
have fragmented, say 1 centimeter stone, yeah? So how
Not
would you know? How would you know what fragments can be left alone?
so if we
It's a
can
commonly asked question.
easily
Yeah. If you use a dusting mode
If it
of
is less
laser
than
and if you
1/4
get
of this,
dusted, yes. Yes, sorry?
if it is
Yeah.
less than 1/4 of this
Less
scope,
than?
1/4.
Yeah, that's one guideline. The other one is if it is less than 4 millimeters or 5 millimeters, those fragments very likely that will come out. The next question will be, how do you know that these are less than 4 millimeter fragments? All of you should know that straight away. Now it's under magnification, so how do you know that your fragment is less than 4 millimeter?
You can compare with the fiber size.
Exactly.
Laser
Exactly. So fiber size is either 0.5 millimeter, that is 500 micron fiber, or if it is 300, as you go on, it is fiber size is 1 millimeter in the standard, but otherwise it can be 0.3 millimeters. So you compare it with the fiber size. And so if your fragments are less than 4 millimeters, some of the fragments you might be able to leave alone. Any other questions? It's a big subject, so I think we can discuss it for hours. But I think
I posted a video on this and the presentation on this MRI prostate. I think it's very important for trainees to go through that. There's a lot of tips there regarding MRI prostate, sir. I posted a video on MRI prostate.
MRI prostate. Oh
video.
yes, I saw it, but I couldn't open it up yet.
Yeah,
so
it's nicely explains all the phases, T1, T2, this contrast, DW, all these things.
Yes, about the pirate system, is it?
Yeah, pirate system.
Yeah.
And how to interpret as well. I mean, it's from our level, not as radiologists, but basic all the stuff there.
Right. Yes. Yes. Because it's becoming a sort of a very important landmark in CA prostate diagnosis nowadays. I think they are trying their best to replace even trust-guided biopsies in some centers on this pirate system, which can even predict with certain degree of accuracy the Gleason score. So because of that, now in future, invasive procedures might go out of the door, depending on the sensitivity of MRI and this type of grading systems. But still, I think it has failed to come to the guidelines to replace biopsy. but I think it soon might happen. Yeah, I think people should go through that. Do we have anything more?
I have one question, sir, not related to
Yeah,
this topic,
sure.
regarding the MRI prostate, sir. In Ampara, I have come across many patients who are having very high PSA, around 35, 25, but repeatedly we do biopsies, and also we are sent to Kanti also to biopsies. Biopsies most of the time negatives. So I have done even one patient for TURP also, that biopsy also benign. So in that case, in the government sector, we don't have much facility to go for a MRI first case. So how we can manage in that situation?
Yeah, I think if the PSA density is disproportionate and
Yes,
you are
sir.
suspecting, and in the DRE also it's ambiguous prostate. Say, I mean, if it's a nodule, of course, you can always direct your biopsy towards that. But ambiguous and it's benign and PSA is elevated, I would rather repeat all these PSAs after a course of quinolone and doxycycline, because in some people, this chronic prostatitis, and where they are, the urine cultures and even semen cultures are negative, they have this intermediate organism infection there. We published a paper also on association between chronic prostatitis and high PSA and CA prostate. So I think always repeat it, number one. So 2 weeks of ciprofloxacin and azithromycin or doxycycline, and you will find that some of these patients, these PSA come crashing down. And these PSAs are generally done in the hospital or any particular lab.
In
That also
hospitals.
something you have to just be his hospital. So I think if they are getting a lot of negative biopsies with high PSAs, I think you have to discuss with the technique of doing the PSA kits and things like that. But I think I wouldn't go unless clinically indicated. Won't go for a biopsy without two PSAs. And your biopsy reports, have you gone through that to analyze it, find whether there are signs of chronic prostatitis in there? So these negative biopsies.
Yeah, it's some biopsies I can find it's a chronic inflammation is there, but I have
Yes. Yeah.
around 5 patients. 2 only had chronic
Right.
prostatitis.
Right. So I think after repeat biopsy also, if the PSA density is high, I mean, you have no option other than going for a biopsy. But I think guidelines says that it's always, you have to do a pre-biopsy MRI. So I think before going for a biopsy, absolutely, there is no absolutely any hurry to do it. So if you can get it done from a teaching hospital, the MRI, you can either you can correlate the pyrad areas with your biopsy. So with the pyrad 4 and 5s, you can go for biopsy. But the only problem is that only depending on the MRI, we can't avoid a biopsy. So still, even if you do a MRI, if the PSA is high in 2 occasions after antibiotics, you have to arrange a biopsy. Only the pre-biopsy MRI will help you to do targeted biopsies. You can target the pyrad 4 and 5 areas when you're doing that. The biopsies are done by radiologists or trust biopsies are done by, So I think that, pre-biopsy MRI will help the radiologist to do, apart from systematic biopsies, some targeted biopsies. So this is a big problem, avoiding unnecessary biopsies. But in Ampara area, just I think try to collect the data. It will be a useful information. The high PSA with negative biopsies can be due to many reasons, such as infection or the PSA kit and everything. So do you always go for PSA density as well?
Yes, sir.
Before doing a biopsy? Calculate
Yes,
the density?
Density, yes, sir.
0.15. So go for the density also. And sometimes large prostates, as you know, can have high PSA. So those are standard ways of avoiding it. MRI, of course, there's nobody is in a hurry. Try to get one done, pre-biopsy MRI. If you're getting too many negative biopsies. But still, even if the MRI says pyrad 1 to 3, or whatever the pirate system, you have to go for a biopsy.
Okay.
But it will help the radiologist.
Okay.
Okay.
Okay. Thanks a lot.
Okay.
Any other questions? What about the present test? Do you have any clarification to be made from the resource persons? The absence of questions, we can conclude the session. Thanks a lot, Professor Nevis Pereira, to use this quality time with us. And Manjula Heras, sir, thanks a lot for participating as an expert. And thanks for the comments. And
Thank you.
thanks a lot for the
Thank you.
Thank you, and good night.
Good night.
Thank you, sir.
Good night.
Good night.
Thank you, sir.
Good night.